Welcome to this educational session. Assalamu alaikum in Arabic, peace upon you. Good afternoon, good evening, good morning to everyone who joined us. We got 602 registrants from Mexico to China and from Russia to South Africa. So welcome all junior pediatric endocrinologists across the globe. And I'm delighted to have you joining us with our distinguished speaker for tonight, Dr. Pratik Shah. Before we gonna delve into the main topic, we got two junior colleagues who are gonna present interesting cases, 10 minutes each, and then we will go into the main topic, which is related to glucose disorders. So yes, Dr. Nida, we see your slides. Please go ahead.
Yes. So, under kind supervision of Madam Sumaya Aftab, I'm going to present this interesting case of an infant with fluctuating blood glucose. So, our index case is a 3.5-month-old boy who presented in PEDS ICU with fever and respiratory distress for 4 days. And upon lab criteria and X-ray findings, he was being treated as bronchopneumonia. So, incidental findings were the hyperglycemia. He was having multiple high readings, more than 350 milligram per deciliter, and urine output was above 5 ml per kg per hour. So, our pediatric endocrine team was involved to see this patient. And on probing the detailed history, he was preterm 34 weekers who was born through C-section due to breech presentation, and birth weight was 1.8 kg. Antenatal concerns were of severe IUGR, and he remained admitted in NICU for 3 days. He was obvious failure to thrive with 2.4 kg weight at age of 3.5 months. So he was product of consanguineous parents with history of one ectopic pregnancy. There was no history of any sibling death or history of diabetes in extended family, and he was the single kid of those parents. On examination, he has distinctive coarse facial features with deep eyes and prominent eyelashes and bulbous nose. There was generalized loss of subcutaneous fat, hypertrichosis, dry and thick skin, with increased pigmentation around neck and axilla. So, he was having persistent hyperglycemia with blood ketones of 1 millimole per liter, and there was mild acidosis in his ABGs. Our differentials were stress-induced hyperglycemia, either neonatal diabetes or any other rare type of diabetes. So at that time, the plan was to monitor blood glucose levels hourly, start IV insulin sliding scale, C-peptide levels should be done at BSR above 150 milligram per deciliter, urgent HbA1c, baseline investigations like LFTs, RFTs, fasting lipid profile, ultrasound abdomen, and KUB and genetics. So HbA1c turned out to be 9.8%. That was high. C-peptide were more than 20 nanogram per ml. His RFTs, LFTs, and fasting lipid profile were normal, though ultrasound KUB showed bilateral enlarged kidneys with subtle calcification in right kidney, and echocardiography showed left ventricular hypertrophy along with septal hypertrophy. So high HbA1c ruled out possibility of stress-induced hyperglycemia, as C-peptide was significantly high, so neonatal diabetes was also ruled out. So we were dealing with some rare type of diabetes. So to summarize, we have this 3.5 months old boy who had biochemical confirmation of diabetes through high BSR and raised HbA1c, and clinical and biochemical evidences of insulin resistance in the form of loss of subcutaneous fat, hirsutism, acanthosis nigricans, and raised C-peptide. So our diagnosis was syndrome of insulin resistance. Once patient was oral free and we were able to off IV sliding scale, he started experiencing fluctuating blood glucose level and there were hyperglycemias and hypoglycemias, and he was not able to tolerate even the fast of 2 hours. This was his blood glucose profile. The first green lines are showing when he was on too early feeding pattern, though there were no hypoglycemias, but multiple readings of hypers were noted. The rest blue lines are when we spaced out the feeding pattern. On spacing out, we observed multiple episodes of hypoglycemias and along with hypers. So we managed him with long-acting insulin detrimer, that 1 unit subcutaneously in morning. Feed was advised frequently every 2 hourly, and his amount was 150 ml per kg per day. Blood glucose monitoring was done pre-feed, and correction was done with regular insulin, as we don't have many pens with us that can deliver the low doses, so we have to dilute the insulin. The scale was advised if the BSR was 300 to 450 milligram per deciliter, then 0.25 units were required of regular insulin, and above this, 0.5 units of regular insulin were advised. So after this management, this was the glucose profile in which there was marked improvement in his glucose BSR readings. His genetics turned out to be the confirmation of Rabson-Mendenhall syndrome, that is autosomal recessive, and there was a mutation in insulin receptor gene. The challenges that we faced as a part of developing countries, we don't have insulin pens that can deliver many doses. Recombinant IGF-1 and leptin are not registered in Pakistan, and we don't have much expertise of feeding gastrostomy and its care. So we manage this patient with frequent feedings, long-acting insulin detrimer, correction with dilution if needed as per scale, regular follow-ups, and the parents were counseled in detail about importance of antenatal counseling for the next pregnancy. So on future follow-ups, there was marked improvement in his blood glucose profile. Number of hypoglycemias reduced over time, as well as hyperglycemias, and his HbA1c was markedly improved, though his requirement of insulin increased with the passage of time. So this is the index case. Pictures have been shared with the permission of family. The kid has coarse facial features with bulbous nose. There's increased hyperpigmentation around the neck, gingival hyperplasia, and his SPL was around 6 centimeter. These are the growth charts. Upon management, he is now gaining weight accordingly, and his height is also on the record. So basically, this is the syndrome of insulin resistance. That is a rare type of diabetes, and it is caused by two different mechanisms that can be acquired and genetics. So as we were dealing with the genetic part, so this kid has insulin receptor mutation, and it turned out to be Rabson-Mendenhall syndrome. The other form of genetically caused this insulin resistance is congenital lipodystrophy. Though obesity, stress, medication, pregnancy, anti-insulin antibodies are the causes that can lead to this presentation too. So syndrome of insulin resistance is an autosomal recessive condition due to the mutation in insulin receptor. This is a bit about pathophysiology. Here we have 3 types of receptor. The first one is insulin receptor. The second one is hybrid. Half part is for the insulin receptor, and the next part is for IGF-1. And the third is receptor for the insulin-like growth factor. So when the insulin receptor is totally knocked down, there is hyperglycemia that affects the pancreas and leads to the pancreatic beta cell proliferation. This will in turn lead to the increased secretion of insulin. When this insulin is unable to work on this insulin receptor, there will be growth failure and loss of fat. And this increased insulin when act on this hybrid and IGF-1 receptors, it leads to the acanthosis nigricans, hyperandrogenism, hypoglycemias, and there will be septal hypertrophy. This is the spectrum of in which we can see the functionality of the receptor lies between 0 to 50%. If the receptor is totally knocked down, as in Donohoe syndrome, this is the severest form with life expectancy of less than 2 years. This severe growth retardation, severe hypoglycemia, and in acanthosis nigricans, hirsutism, and enlarged genitalia. In Rabson-Mendenhall syndrome, there is partial functionality of this receptor, and the life expectancy is usually a bit improved. They can live up to the second decade, but there are also hypos and hypers, and later on they can present with DKA. And there is acanthosis nigricans, gingival hyperplasias, nail and skin dysplasias. The last one is type A insulin receptor, in which there is maximum functionality of the receptor is preserved. They usually present later in life in either teenage or adolescent, and they present with the metabolic syndrome like features, just obesity is not present in them. They can have polycystic ovary disease and acanthosis nigricans. So RMS is rare type of insulin receptor mutation that is autosomal recessive. And Rabson and Mendenhall in 1956 first described it. Exact incidence till now is not known, and we have 50 cases reported yet. So these are the clinical spectrum overall. We can have typical core spatial features with bulbous nose. They can be acanthosis nigricans around neck, axilla, signs of hyperandrogenism, and hypertrichosis. So the clinical picture spectrum lies as shown in previous slide. The course they follow is first they present with hyperglycemias and hypoglycemias that further progress to the persistent hyperglycemias and can present with frank diabetes and DKA. Further on, they have microvascular and macrovascular complications of diabetes and metabolic syndromes, and their life expectancy till second decade with symptomatic treatment. About management, worldwide, the patients are being managed with frequent feeding patterns and avoidance of high carbohydrate diet. The second possibilities are insulin sensitizers and high-dose insulins, metreleptin, and insulin like growth factor 1. Though in Donohoe syndrome, we have total knockdown of receptors, so these modalities are not working in this. In RMS, there is marked improvement in hyperglycemias along with HbA1c and microvascular complications. In type A insulin resistance, the same pattern can be observed. These are some trials that have been done with recombinant human insulin-like growth factor since 1990, in which different dose ranges have been used from like 40 microgram per kg per day to 1000 microgram per kg per day, and they have used it for different time periods. Like some studies have used it just once, and some have continued it for like 8 years or 6 years, and there was marked improvement. So basically, it acts on pituitary to reduce the growth hormone secretion that suppresses glucose production, and it also stimulates glucose uptake in muscles. This was the case report that was presented by Akruk et al. And he notified the same genetic mutation that we have in our index case. Till now, total 13 mutations variant in insulin receptor were reported. Mostly are homozygous or compound heterozygous. And our index case had this replacement of serine with leucine on exon 4 and encodes abnormal alpha unit of insulin receptor. So this was the case that was presented by Cook et al. In 1994. He presented a 3-year-old boy who presented with diabetes and insulin resistant, though his both parents were unrelated, but they were heterozygous carriers. His one sibling passed away at 8 years due to uncontrolled diabetes, and he lived up to 20 years. There was no history of diabetes in his extended family too. So there are varied presentation depending on the severity. Mostly presented later in childhood with uncontrolled diabetes, but our index case presented earlier, and it is fatal within like 2 years. The range is 22 months and 70 days. Thank you so much.
Thank you very much. This is very fascinating and interesting, very well prepared. Thank you. Thank you very much.
Thank you.
So that happens. Perfect. Yes, we see it. It's full. And
I'm Dr.
go on.
Vishwan here, fellow pediatric endocrinology under supervision of Dr. Sumaya Aftab. And I'll present an interesting case of a child with unexplained recurrent fits. So we had about 1.5-year-old male child with history of recurrent seizures since 8 months of age, and previously being diagnosed as epilepsy under neurology follow-up, but seizures remain uncontrolled despite being on multiple anti-epileptic drugs. And then the kid presents at about 1.5 years to a tertiary care hospital to us with concern of hypoglycemia noticed during the last episode of seizure. Regarding the previous history, he was full-term, normal birth weight without any history of gestational diabetes or any other significant events. Regarding family history, there is history of consanguinity. All siblings are alive and healthy. Only the one paternal uncle has type 2 diabetes, and there isn't any history of epilepsy or inborn error of metabolism or any hypoglycemias in the family. Regarding past history, there wasn't any particular pattern of seizures. It was observed at any time, mostly during the day, and there was no known any precipitating factors. And he was on levetiracetam and sodium valproate, and a developmentally normal child. On examination, there were no syndromic facies. Weight was on the 3rd centile, length was on the 3rd centile, BMI was 10th centile. Systemic view wasn't remarkable. There was no hepatosplenomegaly. Cardiovascular system was unremarkable. Patient was then admitted in endocrinology ward, and we did BSL monitoring. Food diet was noted. There wasn't any particular pattern of seizures. After routine feed, the kid had an episode of hypoglycemia. PSR dropped to about 34 milligram per dl. We did critical sampling along with all the routine baselines like complete blood counts, LFTs, RFTs, serum electrolytes that were turned out to be normal. MRI brain was also normal, echo was normal, ultrasound was also normal. EEG showed only the epileptiform changes. Well, I'll explain the hyposcreen here. Blood ketones were less than 0.1. ABGs were normal. There were no acidosis. Insulin was detectable. It was, in fact, significantly raised, 32 international per ml. C-peptides were normal. Ammonia was slightly raised, 186. Lactate was normal. Triglycerides were within normal range, as we don't have free fatty acids option. Growth hormone was 0.8 nanogram per ml. Cortisol was 57 microgram per dl. And we don't have option of non-esterified free fatty acids here. So we also recheck for growth hormone cortisol levels. And at 30 and 60 minutes, it turned out to be growth hormone 160 nanogram per ml. But IGF-1 levels were within normal range. Cortisol was 14 microgram per dl. Well, such test results of growth hormone on single reading, we can't say it's growth hormone deficiency without any insulin tolerance or other stimulation tests. So, well, to interpret these critical sampling, if hypoglycemia is noted, I'll briefly explain our index case, as there was no acidemia and it was hypoketotic hypoglycemia. Well, we don't have free fatty acids, but regarding considering history And there was most likely suspicion of hyperinsulinism, the raised insulin levels, and neonatal hypopituitarism was ruled out as MRI was normal. Well, and then we started management of this child. Octreotides in the form of sandostatin were started at 5.6 units per kg per day, 6-hourly. Diazoxide was not available. Fast tolerance as discharge was 8 hours. But the kid later presents with recurrent episode of hypoglycemia, usually precipitated by protein intake. Like mother was giving a lot of eggs, and then there is hypoglycemia is there. BSR dropped to 30s. Well, then we planned genetics, and sample was sent. Genetics turned out to be GLUT1 mutation. It was heterozygous. Both parents were normal, so it was rather de novo mutation. So in a nutshell, we have 1.5-year-old boy with biochemical confirmation of congenital hyperinsulinism in the form of non-ketotic hypoglycemia, raised insulin levels, and evidence of hyperinsulinism hyperammonemia syndrome in the form of hypoglycemic seizures precipitated with protein diet and raised ammonia levels, and confirmed on genetics by de novo GLUT1 mutation. So management plan was changed after that. We somehow arranged and started diazoxide at 5 mg per kg per day along with diuretics and protein restriction. But during follow-up, at a certain point, they were unable to further taper the sandostatin, like they were stuck at around 10 units per kg per day. And then we stepped up the dose of diazoxide to 7 mg per kg per day. And then within 1 week, they were able to taper off sandostatin. Current status is the kid is 2.5-year-old, weighing 11 kg in 10th centile, height is also in 10th centile, BMI is 25th centile. Sandostatin is taper off. There are no side effects observed yet. Fast tolerance is around 18 hours, and blood glucose range is 83 to 150 milligram per DL. And there are hardly any episodes, in one episode of hyperglycemia observed in the last 2 months. And well, fast was done at home. So after that, safety fast ketones couldn't be done because of affordability issues and fasting at home. So we further plan for such kids is we need diazoxide and make sure the availability, as it's not registered in Pakistan. So we face a lot of difficulty and affordability issues. Genetic sampling, we are collaborating and trying to do genetic samplings of such kids. And we are thankful to University of Exeter and Congenital Hyperinsulinism International. For that, we are managing to send such genetics. And we have created a peer support group, and we are planning to start a teleclinic for kids as they belong to far-flung areas. Well, the challenges we facing in developing countries are lack of diagnostic facilities. These are not easily or widely available at all the centers or the government centers, and when available, they are usually most of the people can't afford them. And obviously the unavailability of diazoxide, and it's not registered here. And a lack of expertise in feeding gastrostomy tubes. And usually there are no much support groups.
And very nicely presented. Thank you. So due to time, we're going to move with our eminent speaker, Dr. Pratik Shah, a friend and a very humble person, but he's a very experienced person as well. Pratik is a consultant in pediatric endocrinology and diabetes at the Royal London Children's Hospital, Barts Health NHS Trust in London. He is also honorary senior clinical lecturer at William Harvey Research Institute, Queen Mary University, London. He is a visiting pediatric endocrine consultant at Portland Hospital for Women and Children, and he's adjunct professor in pediatric endocrinology at Baikaka University in Karamsad in India. Pratik did his PhD in the field of congenital hyperinsulinism and specialized in children with all forms of glucose disorders, whether rare or syndromic forms of hypoglycemia, diabetes, and ketotic hypoglycemia. And he has led the highly specialized NHS England service for congenital hyperinsulinism. He also specializes in managing children with severe obesity and is part of multidisciplinary team for bariatric surgery in children. His research team is working on identifying and understanding molecular basis of non-diabetes hypoglycemia, including syndromes, and identifying novel therapies in hypoglycemia and hyperinsulinism. The CV of Dr. Shah is very extended and lots of achievements, but he's got he's passionate about including the high quality teaching and training in the field of pediatric endocrinology. And he organized various national and international endocrinology meetings and symposium, mainly on hypoglycemia disorder in children. So it's our opportunity tonight to have him with us. And then if you got your questions around the glucose disorders, so he is the right person to ask tonight. So his talk is going to be about glucose disorders and rare syndromes and neonatal diabetes mellitus. Without further delay, Dr. Pratik, floor is yours.
Thank you so much, Hussein, for inviting me. And hello, everyone. I hope you can hear me. Is that okay?
Yes, it's all right.
Thanks. So what I'm going to do is I'm going to try and summarize. I think the two cases were really very good, and actually it's kind of set up the scene. It actually has made my job a bit easier. But what I'm going to try and do in the next 45 minutes is first talk about the historical perspective, as when were the first syndrome that were reported that had caused hypoglycemia or diabetes. I'm then going to go through some literature review. Now, in over the last several years, there have been a lot of syndromes or a lot of multisystemic conditions that has been reported that causes hypoglycemia as well as diabetes. Well, I'm going to try and simplify it. But the first thing what I'm going to do is talk about hypoglycemia, which will be different causes like hyperinsulic hypoglycemia, ketotic hypoglycemia, hypopituitarism, and adrenal disorders. And then I'm going to talk about few cases or few conditions, syndromic causes of diabetes mellitus, and then neonatal diabetes mellitus. So when we talk about the history, the hypoglycemia, it's a Greek term, and what it means, it's under sweet blood. And it was first described in 1922 by James Collett when actually he was working on purifying insulin. And interestingly, the first syndromic condition that was reported with neonatal hypoglycemia was about more than 50 years ago. And obviously that you can clearly see that it was Beckwith-Wiedemann syndrome, which is what later described. And then the initial first sort of familial form of diabetes was also described about 50 years ago, 55 years ago, again, with those with familial diabetes with autosomal dominant inheritance. And subsequently, obviously, then we've been able to find more and more genetic causes. However, there are still some of the conditions we are still not able to identify a genetic cause, or we are still not able to understand the exact mechanism of glucose disorders in some of the syndromes. And why is it important to diagnose this condition? And again, this is, I always try and tell, trainees and making sure that it's really, really critical to actually get the hypoglycemia screen done in a timely manner, but also making an appropriate diagnosis. And the reason is because some of these conditions, if it is a hypoglycemia, if it's causing hypoglycemia in children, it can later on lead to diabetes. And now you can see this is an evidence that was published again nearly 50, 60 years ago in 10 children, where the natural history showed that children with idiopathic hypoglycemia had subsequently developed impaired glucose tolerance or diabetes mellitus later in life. And what was found in this, and it was published in NEJM, that actually in this group of children, there was a positive family history of diabetes. So either the parents or the siblings also had reported diabetes mellitus. And another case series, which was published again similar time, which showed there were two children who had hypoglycemia, had frequent hypoglycemic episodes when they were unwell, and they eventually developed diabetes mellitus, and one of them needing insulin, the other one was on oral medication. So when we talk about hypoglycemia in children, when I ask, what is a normal blood glucose range? And interestingly, even within the same neonatal unit or within the same center, you will have, different healthcare professionals saying different levels of blood glucose range that would be acceptable to them. And we've been discussing about what is a normal blood glucose for many years, but we still do not have any universally accepted definition of hypoglycemia, which will actually determine absolute clinical risk or can predict sequelae. So it is really important to understand, and hence the hypoglycemia screen, which is a critical samples, is really important, so that it helps us to evaluate the plasma glucose concentration with the in association with the presence of risk factors, the clinical state of the child, and what are the intermediate metabolites or alternative fuels if that are present at the time of hypoglycemia. And the reason is because if it is non-ketotic hypoglycemia, then they are at a risk of hypoglycemic brain injury. So it is really important that we actually identify and aim for a higher blood glucose concentration in those children who have non-ketotic hypoglycemia. And sometimes we have to have individualized approach to manage some of these children, like in the second case that was actually just mentioned. In terms of hyperinsulinism, we've just recently published international guidelines. We aim for a higher blood glucose threshold. In the UK and EU, we kind of aim for about 3.5 millimoles per liter or 63 milligrams per deciliter as the cutoff for treatment. Again, this is a very similar table that we had in the second case. Like I mentioned, it's really important to actually get a critical samples at the time of hypoglycemia. But again, when you kind of look at whether there is any acidosis, if there's no acidosis, you look at the ketones and fatty acids. If they both are low, then you kind of either think of neonatal of hyperinsulinism, or sometimes hypopituitarism in newborns, or also sometimes transient cause of hyperinsulinism. But if there is raised fatty acids and low ketones, then you think about fatty acid oxidation disorder. So it's really important to get the fatty acids and ketones at the same time of during the hypoglycemia screen. However, if there is acidosis with increased lactate, then you think about gluconeogenesis defect. But if there is increase in ketones, so if it's a ketotic type of hypoglycemia, then you think about various forms of metabolic causes, which is glycogen storage diseases, or in terms of endocrine causes, then we think about growth hormone or cortisol deficiency. And to do this, sometimes we also have to think about doing a control diagnostic fast. So if you're not able to really take critical samples at the time of hypoglycemia, then sometimes we have to bring them in for a control diagnostic fast. And preparation for this is really critical. And why do we talk about signs and symptoms of hypoglycemia? And do we actually see children with having signs and symptoms of hypoglycemia or ketosis all the time? And actually, not really, because if they have had recurrent or frequent episodes of hypoglycemia, then children can be asymptomatic. So it is really important to understand that if they do not have any symptoms at the time of hypoglycemia, then it's even more important for us to actually monitor them, as well as make sure that we identify if there is any asymptomatic hypoglycemic episodes. And like I said, it is really important to understand that if they have hypoglycemic episode, because it's a medical emergency, we make sure that we have to treat them promptly, and also make sure that we do investigations, as this has got short and the long-term outcomes if we do not treat the hypoglycemic episode. So coming to the syndromic causes of hypoglycemia, which is either could be ketotic or non-ketotic hypoglycemia. Now, when you talk about syndromic causes of hypoglycemia, we want to try and make sure that either it could be defect in hormonal pathways or metabolic pathways. And for the purpose of the talk, I'm actually going to talk about endocrine conditions. I'm not going to really talk about the metabolic side of things. But when we are looking into a cause of hypoglycemia, and like I said, in the last several years now, we've increasingly identified more and more syndromes that actually can cause glucose disorders. It's really important to look for all phenotypic features as well as the other systemic involvement. You think about, can all these things come together, and is there a particular syndrome that can actually cause this condition? And like I mentioned, hypoglycemia screening is really important. And then if you suspect a genetic disorder, then it's important to undertake target gene panel or whole exome or genome sequencing. So in terms of the hypoglycemia, I've kind of divided this condition. So first I'm going to talk about hyperinsulinism, then I will talk about ketotic hypoglycemia, and then adrenal and pituitary disorders. So when we talk about syndromic forms of hyperinsulinism, the second case very nicely highlighted what is hyperinsulinism. So I'm not going to go in detail, but it's low fatty acids, low ketones, detectable insulin at the time of low blood glucose concentration. And there are several syndromes that actually can cause hyperinsulinism, but I'm going to concentrate on few important syndromes which are actually more common as well as causes hyperinsulinism, and is more frequent in those conditions. So when you talk about the syndromic conditions, is overgrowth syndrome like Beckwith-Wiedemann syndrome or Sotos syndrome, postnatal growth failure like Kabuki syndrome, Costello syndrome, Turner syndrome, which is like chromosomal abnormality like Turner syndrome or trisomy 13. Timothy syndrome, Usher syndrome is really, it's very rare, but it's common in certain part of the Middle East. It's Donahue syndrome and then Rubinstein-Tybee syndrome. Now, I apologize for a very busy slide, but I actually wanted to highlight this. The reason is because, like I said, there is a long list of syndromic conditions that can cause hyperinsulinism. But if you kind of think about, and if you divide them into different groups, like overgrowth syndrome, so the Beckwith-Wiedemann is the most common syndrome, which causes macroglossia, abdominal wall defects. They can have crisis, umbilical hernia, hemihypertrophy, and they have at a risk of developing tumors. It's also the second one is Kabuki syndrome, which is KMT2D or KDM6A. These are the two genes that are implicated to cause Kabuki syndrome. However, the KMT2D is the one which actually is generally more common to present with hypoglycemia and hyperinsulinism, and generally they are diazoxide responsive. But again, you look at the phenotypic features, they can have arched eyebrows, long eyelashes, developmental delay, heart defects or scoliosis, and short stature and hypotonia. And coming to mosaic Turner, now again, we come across Turner syndrome, but especially those with mosaic Turner syndrome, they are at a risk of hypoglycemia. And what is important is actually when you see this children in clinic, it is really, really important to ask about signs and symptoms of hypoglycemia. And if obviously there is any concerns about signs or symptoms of hypoglycemia, then it is important to then do some blood glucose testing. So over the last several years, there have been quite a few publications, and I'm just going to highlight those publications, what actually came out from those publications. So there was an expert consensus document that was published for Beckwith-Wiedemann syndrome. And the recommendations were that all children with suspected Beckwith or proven Beckwith-Wiedemann syndrome should have a fasting test before they go home, because up to 2/3 of children with Beckwith can have hypoglycemia or hyperinsulinism. There was a study that was published in Japan, which actually in particular looked at Beckwith-Wiedemann, Sotos, and Kabuki syndrome. And what they found is they had more than 300 children who were actually recruited across Japan. And they found that most of the children were responding to medical treatment, but few of the Beckwith-Wiedemann were very severe, requiring pancreatectomy. And then we published our data for 15 years and showed that, how some of the syndromic conditions they actually presented. So we had 61 children in our case series, where we found that of about nearly 87% of them had hyperinsulinism and 13% of them had hypoglycemia, but they did not have underlying clear diagnosis. And when we looked at those 8 children who had hypoglycemia, and this is from the publication that you can see that, what different syndromes can cause hypoglycemia at the time of illness. So mainly it looked like they had ketotic hypoglycemia. But also, again, it's important to remember that 2 of them also had growth hormone deficiency. So again, growth hormone deficiency can cause hypoglycemia, ketotic hypoglycemia. So those patients were CHARGE syndrome, Kabuki syndrome. One of them had a chromosome deletion in 3q22.1, and the other one had in chromosome 9, and also 6p chromosome 6 as well. And then one of them had 16p11.2, which has actually now recently been published that this gene actually encodes genes which it has got genes that actually causes insulin secretion. So it's really important that some of this syndromic conditions can also encode transcription factors for the genes those are responsible for insulin secretion. Now, I'm just going to highlight about this two syndromes, which is really important, I think, is Beckwith-Wiedemann syndrome. And like I mentioned, that majority of Beckwith, or up to 2/3 of patients, can have to have hypoglycemia. So it's really, really important to actually do a fasting test before they go home. But more importantly is the paternal 11pu PD uniparental disomy one, which is actually can cause severe hyperinsulinism. And what has been reported is that those with uniparental disomy can have focal form of hyperinsulinism. So it's important to undertake appropriate scanning if they are not responding to treatment, because they can have focal form of hyperinsulinism. And coming to Kabuki syndrome, like I mentioned, there's two genes mainly implicated with Kabuki syndrome, which is KMT2D and KDM6A. But KMT2D is the one which is more commoner, which is associated with hyperinsulinism, and generally they respond to diazoxide. The mechanism of how this is causing hyperinsulinism is still not fully understood. However, again, what has been highlighted is that they probably are involved in transcription factors, which is involved in insulin secretion. What we found in our study that about 80% of the children were diazoxide responsive. So again, I think obviously with the second case, there is an issue of having a diazoxide supply in certain countries, but this is at the moment only oral treatment that is available. So most of these children are diazoxide responsive, and nearly 2/3 of them would be coming off medication by 2 years of age. So it's really, really important that to assess the response to medication or diazoxide and regular follow-up, so that actually if they do outgrow treatment, then it's important to consider taking off treatment and monitoring blood glucose, and if they're able to fast appropriately for their age. Like I had mentioned about the Sotos syndrome or the overgrowth syndrome, and it's mainly due to mutation in the nuclear receptor binding protein 1, NSD1. But I also wanted to highlight, because the first case was really interesting, and I want to highlight about the insulin receptor mutation gene. Now, we published this case series where there's one, interestingly, the two siblings with Donahue syndrome who had pancreatic exocrine insufficiency. Now, this has never been reported. So you can also see that some of these syndromic conditions, their phenotypic features is also actually, there's increased number of phenotypic features that now we're being actually finding it. So in this case series, what we found was that along with they had, cardiac problems or clotting disorders and abnormal liver function tests, they also had pancreatic exocrine insufficiency. And they were managed with a recombinant IGF-1 treatment. But we also reported a very milder form, again, that as was shown in the first case, where the child had type A insulin resistant due to heterozygous mutation in insulin receptor gene. Now, this child had neonatal hyperglycemia, and like we had seen in the case, these children are known to have postprandial hyperinsulinic hypoglycemia, and I'm happy to discuss about the management at the end. But what is important is to understand is that children can present with hyperglycemia, or they can develop postprandial hyperinsulinemic hypoglycemia, and sometimes is giving slow feeds can be really helpful rather than giving a bolus feeds. Coming to ketotic hypoglycemia, so obviously now we've kind of we've looked at the hyperinsulinic hypoglycemia, but coming to ketotic hypoglycemia in certain syndromic conditions. Now, ketotic hypoglycemia is increasingly being recognized, or I would say idiopathic ketotic hypoglycemia, whereas we have not been able to find any underlying metabolic or endocrine causes, and that is now increasingly being identified in certain syndromes. We actually published in our case series with Canini-Lenz syndactyly, which is due to LRP4 mutation. But these two siblings actually had a very clear history of becoming hypoglycemic when they were unwell, and actually did get milder as they grow older. But there was no other endocrine or metabolic cause found. And again, this was actually never been reported. So sometimes it's really important to follow up these children. And usually they can get, they can get milder as they grow older. There was a large case series published in New England Journal with phosphoglucose mutase 1 deficiency, which is PGM1. And this is actually a mixed type of congenital disorder of glycosylation, CDG syndrome, and PGM1, which is mainly responsible for reversible conversion of glucose 6-phosphate to glucose 1-phosphate. So what happens is that this actually can cause hypoglycemia, and they can also have adrenal disorders. So I'll come to when I talk about adrenal disorders. It also causes adrenal insufficiency, which is a cause of hypoglycemia in this group of children. But they're typically present with bifid uvula, hypogonadotrophic hypogonadism, short stature, dilated cardiomyopathy, and liver enlargement. And interestingly, now there has been more work going in children with Down syndrome, which actually we do come across a lot in our practice. And it's important to again ask about signs and symptoms of hypoglycemia. And some of these children can present with hypoglycemia when they're unwell. And what was found is that they've done a mouse study, and we found that there is actually reduction of glycogen synthase kinase 3 beta, which is GSK3 beta phosphorylation. And this is actually responsible. So GSK3B is responsible for glycogen synthase. So if you have low GSK3B, there is low glycogen synthase in liver, which is very typical of glycogen storage disease 0, type 0. So again, with Down syndrome, what they have found is that some of these children can present with hypoglycemia, and they may need sort of emergency treatment plan, especially when they become unwell. And interestingly, there was a study that was published in one of the centers in US, which actually looked at children who are presenting with ketotic hypoglycemia in A&E. And what they found is about out of 62 children, nearly, I think, 10 children had underlying issues, or had some of the metabolic or endocrine problems. So again, just have to think about what can be the cause. But in that, what they found is one of them had GSD9, the other one had Russell Silver, and one of them had growth hormone deficiency, and the other one had SLC16A1, which is actually can cause exercise-induced hyperinsulinism, which is mainly involved in pyruvate and lactate metabolism. Coming to hypopituitarism and hypoglycemia, interestingly, again, ketotic hypoglycemia has been reported in 1979. Again, this was nearly about 50 years, 45 years ago, where they found that children with hypopituitarism can present with ketotic hypoglycemia. But what is important is that when we do hypoglycemia screen in these children, I always kind of say that please, take with a pinch of salt when you interpret these results, especially the cortisol and growth hormone. There has been several studies now which has been shown that the cortisol and growth hormone may not be high enough at the time of hypoglycemia screen. The reason is it can take sometimes a bit longer for the counter-regulatory hormones to start kick in. So if you do have low levels, please interpret with caution. You have to either repeat it, or you have to do other dynamic function tests to confirm if they are deficient in growth hormone or cortisol. We published again with a condition with eukaryotic initiation factor 2, which is EIF2S3, which is typically linked. It is actually expressed in pituitary gland as well as pancreas. And we had siblings where they had this mutation, which showed we had initially had hypoglycemia. There are adults which were published, which were reported to have diabetes mellitus. So again, like I mentioned earlier, that it is really important to think about that when you're diagnosing a condition, when you actually think about a syndromic condition, think about following up as well in the long term, because some of these individuals may develop diabetes mellitus. And also the treatment also will depend, because most of these children will end up getting insulin, but it's not necessary that they may need insulin. They might be okay again with oral medications. And there was another mutation that was reported some time ago with forkhead box A2, which is FOXA2 mutation that causes hyperinsulinism, hypopituitarism, and craniofacial abnormalities. Coming to adrenal disorders, again, very similarly, about 50 years ago, there was a first report about ketotic hypoglycemia in a 4-year-old boy with adrenal cortical insufficiency. So again, it's very well known that children can present with ketotic hypoglycemia in this group of children. And like I was mentioning about PGM1 deficiency, this was shown that actually some of these children can present with adrenal insufficiency, and it's really, really important to look at those children with the multiple phenotypic features. And we published our genetic analysis of the primary adrenal insufficiency in children who had of unknown etiology, and we've shown, like, we had about 25 years experience with my colleague Lou Methrel and John Ackerman actually were leading on this project. And what we found is that we had a group of children with CYP11A1 mutation. Again, it can cause very mild adrenal insufficiency and can cause hypoglycemia. And how they presented was that this child was about 3 or 4 years old and had recurrent hypoglycemia when the child was becoming unwell. The cortisol levels were, I would say, reasonably sort of just borderlines what we would expect, like in the UK we'd kind of say 220, 230 nanomoles per liter, which was something that we would accept as is okay. But when we did an ACTH was significantly high. And then subsequently doing synectin test that showed that the synectin was suboptimal. And then we actually did genetic analysis that we found to have, found to him have CYP11A1 mutation. So again, it's really, really important to think about the setting as how you interpret some of these results, because then when you think about in retrospect that you would have expected a cortisol level to be much higher sometimes at the time of hypoglycemic episode. So coming to syndromic forms of diabetes. Now, again, there are lots of genetic conditions that has been reported to cause syndromic forms of diabetes, and I won't be able to go on all of them, but I'm just going to try and simplify in some of the conditions that actually causes diabetes mellitus. Now, the mutations, which is GATA6, GATA4, and RFX6, which actually can cause mainly can cause congenital heart defects, which is very common, but also it is not that common in children. However, it does actually, children do present when they are in adolescent age group or sort of in teenagers when actually they flip into diabetes. So again, some of these conditions would need insulin treatment, but to just think about that, how we actually monitor, but they also can cause pancreatic exocrine insufficiency. Coming to pigmentary hypertrichosis and insulin diabetes syndrome, which is PHID, which is caused by SLC29A3 gene. Now, again, this is a multisystemic disorder that causes heart anomalies, hypogonadism, hearing loss, hepatosplenomegaly, and some of these children would need insulin treatment. We actually published, and the reason for me to show this case and this mutation is because we showed that the DNA JC3 gene, so we had siblings who had short stature, severe developmental delay, hypothyroidism, and hyperinsulinemic hypoglycemia. And the two siblings had very, very similar features. However, looking at in the literature, we found that there are adults with DNAJC3, which can cause diabetes mellitus and multisystemic neurodegeneration. So again, this is a co-chaperone, which actually involves in terms of because the DNAJC3 gene is present in various sort of organs, including the brain as well as the pancreas. So how actually this really causes. So sometimes when you have activating mutations, so again, just thinking about if there's an activating mutation, then it can cause diabetes, or inactivating mutation can cause hypoglycemia. And we know about Wolfram syndrome. So again, with this Wolfram 1 and Wolfram 2, which has got GI involvement. Wolfram 2 comes with a GI involvement. But again, it's really important to think about that if they do come up with diabetes mellitus, and if they have, Wolfram 1, then you think about, screening their eyes, for hearing, as well as looking for diabetes insipidus. So knowing the phenotypic features really help us to actually understand that what other systemic involvement can occur. And also then it is important to screen them for those other systemic involvement. I'm now going to just briefly talk about neonatal diabetes mellitus, which is actually not very common, and we don't come across that often. So what's important is that it can occur up to first 6 months of age. 80% of them is likely to have genetic cause. They can either be transient or permanent forms, and I'll show you in a table with the link of the genes that can cause neonatal diabetes mellitus. But it is reported up to 1 in 100,000 or 1 in 150,000 children. So in term infants and premature infants which are born more than 32 weeks, they are more likely to have monogenic cause. However, in this one of the studies that showed that up to 31% of preterm infants, which is less than 32 weeks, were diabetes, where they were also diagnosed with monogenic cause. So it is really important that children, when you start thinking about neonatal diabetes, or in babies, when you start thinking about neonatal diabetes, then screen them for genetic, or send their bloods for genetic testing. It should be considered in infants with insulin-dependent hyperglycemia, with blood glucose persistently more than 250 milligrams per deciliter or more than 14 millimoles per liter, without an alternative etiology, or if hyperglycemia persists for longer than 7 to 10 days. So again, when we look at the literatures about the definition as when would you suspect neonatal diabetes mellitus, and think about if you do not have any causes, then anything more than 14 millimoles per liter or more than 250 milligrams per deciliter would think about neonatal diabetes. Now, this is a cartoon model which I've taken from one of my publications, but I just wanted to try and show you a few things that might help you to understand a little bit of the genetics. This is a beta cell, and the PER6.2, which is potassium inward rectifying channel, which is encoded by KCNJ11, and sulfonylurea receptor 1, which is encoded by ABCC8 gene. They are actually expressed on the beta cell membrane. So you have to think about, like I was mentioning to you about in inactivating mutation, you will find hyperinsulinism, but in activating mutation of these genes, we will find neonatal diabetes mellitus. Obviously, there are other mechanisms of how insulin is secreted by the beta cell, but the most common mechanism is involving the KATP channels. This is what it works. But there are other mechanisms that is involved in insulin secretion. So when we talk about the prevalence of neonatal hyperglycemia in preterm infants, it can be up to 25 to 75%. But it's sort of more common in the first 3 to 5 days after birth, or it can be up to 10 days of life. But usually then it resolves within 2 to 3 days after its onset. So you sometimes have to think that in preterm infants, we do see hyperglycemia, but it usually settles down. But there is no kind of clear consensus of what would be the treatment for neonatal hyperglycemia. So there are different units who have actually published and showed their recommendations. And in Chicago, they said that if the blood glucose is more than 300 milligrams per deciliter, then you consider starting use of insulin. However, in the UK, some centers use more than 14 millimoles or more than 250 milligrams per deciliter. If their blood glucose is persistently high, then you consider starting insulin. But if the blood glucose is between 180 to 250, then you monitor them. But in one of the studies that was by Rosens et al., that showed that due to low risk of short-term hypoglycemia in neonates and the high risk of insulin-induced hypoglycemia, they recommended reserving insulin therapy for glucose levels of more than 500 milligrams per deciliter. But again, you can see that how people are actually using insulin, because they recommended using it more than 500 milligrams per deciliter. But again, it was felt that there could be significant osmotic changes that can lead to ventricular hemorrhage, which if the blood glucose goes beyond 360 milligrams per deciliter. So I think the general consensus of people using insulin in newborns is anything more than 250 milligrams per deciliter. But in some centers, people use up to more than 300 milligrams per deciliter. But very importantly is that you then examine for other features. So you have to examine for pancreatic exocrine insufficiency or test for pancreatic exocrine insufficiency, look for a pancreas if there is atrophy of pancreas, test for vision, hearing, as well as check for heart and other systems. Obviously send for genetic testing if you feel that the hyperglycemia is persisting beyond first 2 weeks of life, or if you had to initiate insulin treatment. If you do start insulin, the general consensus again is starting at 0.02 to 0.05 units per kilo per hour as an IV infusion. We sometimes use Medtronic pump, which is the diluted insulin, or you can give it IV infusion. But if you are going to start as a subcut dose, then sometimes the dose would be 0.1 to 0.15 unit per kilo per dose with a fast-acting insulin. And that should be given just prior to the feeds when the blood glucose is greater than 11 to 14 millimoles per liter. This is a sliding scale that we use in our unit. I'm sure that you would have your own sliding scale as well, but it's really important that how we actually try and use it. Now, that actually helps us to determine the total daily dose of, what the total daily dose for the insulin requirement. I sometimes kind of say, look, you do start on insulin, you want to try and get the blood glucose in the normal range, and send off the genetic test. But it also then helps that sometimes we may have to change to the oral anti-diabetic agent depending on once you get the genetic diagnosis. Like I had mentioned about the KATP channels, again, I just want to try and highlight, because this is a more common genetic mutation that you will find in neonatal diabetes. So the KERG 6.2, which is a potassium inverter-rectifying channel, or sulfonylurea receptor, SUR1, or insulin receptor, insulin gene. So when you look at it, they can actually present. So this is a frequency of what is a more commoner. So with the first two KATP channels, they can present with Dendt syndrome, which is with diabetes, epilepsy, or neurodevelopmental delay. But then they can also have permanent neonatal diabetes mellitus or transient neonatal diabetes mellitus. They can, with SUR1 and insulin gene, they can present like type 1 diabetes. But again, late, in older sort of individuals, they can present with MODY or type 2 diabetes or gestational diabetes mellitus. And I've just mentioned about Walcott-Relison syndrome. Again, I'm sure that you would know about and how they present, but this is one of the common syndrome which I wanted to mention, how they present. So again, they present with neonatal diabetes mellitus, and due to eukaryotic initiation factor 2, which is EIFH2AK3. Which is typically causing bone problems. They can present with osteopenia, multiple fractures, or tooth discoloration and skin abnormalities. Typically, they're present with liver failure, renal failure, so multisystemic failure. And obviously, the insulin is a treatment of choice, but some of the children would need transplant. And it's actually because of the multi-organ failure. The life expectancy is not great with this condition. This is a long table again for the genetics causes of diabetes mellitus, and just wanted to highlight that like I said, the genes are actually now there are more and more new genetic conditions that are being actually found to cause diabetes mellitus. But what I'm really keen and what is more important is to concentrate on the second column, which is the transient versus permanent. And that's really, really important because that helps us to understand that actually what is the long-term implications of this condition, of these genetic conditions. And again, and then the last column that shows treatment again, which is very, very important to think about, that can we actually trial oral anti-diabetic agent in some of this treatment? And I'm happy to discuss about the first case, which is really, really interesting, and we can talk about what we can try. And I found this table really useful. I've put this here in the slide, just something for people to be aware of. It's obviously there you can see a lot of errors, but I just wanted to show you that this was a paper which was published in 2015 in Lancet, which was on international cohort study. But what you can see is what common genes what is the common genes that we come across in neonatal, in neonatal diabetes. But you can see that also what is the long-term outcome. So if you look at the first one, which is the KCNJ11ABCC8, you can see that they can also have diabetes remission. You can also see that they can have alternative treatment for hyperglycemia. And you can also see that they can also have neurological features. So when you think about, what kind of implications they have with this condition. So it helps us to actually discuss the outcome of diabetes in some of this, group of children. And like I mentioned about Walcott-Relison, you can see EIF2AK3, which is in this box where you can see they usually would need insulin treatment, but they can have neurological features as well as they will have other features. So it just helps us to understand that what are the features that can be associated with this genetic condition. To summarize, it's very, very important to have thorough history and careful assessment of possible genetic syndrome, because it really helps us to know, is there any underlying illness that is precipitating them to cause glucose disorders? Either it is hypoglycemia or hyperglycemia. And it is also then very important then to look for other systemic features, because again, the treatment will be dependent on the diagnosis and also if there is any other systemic involvement. When we think about some of these genetic conditions, yes, it can be quite hard to understand, but we also have to think about, there can be variable penetrance. So we do see children that there are some in the family who are very mild and there are some who are actually having quite severe condition. So we also have to think about, there could be variable penetrance in the family members. But then, like I mentioned, think about the genes that may cause hypoglycemia in children and then diabetes in the family members or in adults. And I always kind of would be, keen. And this is a common question that comes often, in the clinic is like, if the child has got hypoglycemia, the question is, can they develop diabetes later in life? But which we, sometimes we don't know. Because they have a strong family history of diabetes. So again, if we've not found a genetic cause and if we don't know what exactly the cause is, then sometimes it's important for family to be aware of the signs and symptoms of diabetes as well, just in case if they do develop any diabetes later in life. Again, role of genes in the pancreas development is really important to understand, and some of them are involved in transcription factors that regulates insulin secretion. So again, we still try and understand, and this is one of my research to understand some of the mechanism in syndromic conditions, why actually some of these conditions can cause glucose disorders. And again, diagnosis is very important. So you do take critical samples at the time of hypoglycemia, which is either at the time when they're present with hypoglycemia or you undertake controlled diagnostic fast. And in fact, one of the papers that was found that there were a significant number of patients that was referred to diabetes clinics who actually can carry mutation in the monogenic diabetes gene, which is up to 6%. So, I guess it depends on which clinical setting you are in and where do you practice. But again, keep your mind open, keep thinking about other causes of diabetes, and is not everyone has got type 1 diabetes. So if you are suspecting MODY or genetic cause, then please refer them for genetic testing. So I would like to thank Hussain and the team for inviting me, and would like to thank the patient, the family organization who I work with, my colleagues in the UK, India, and internationally, And like I said, I've got this research interest, so I'll be very happy to be contacted if you have any queries. Thank you very much.
Wonderful talk. Thank you very much, Pratik. It's amazing as usual. Always a pleasure to listen to your talks. Now we got a number of questions. So people are thanking you in the chat box. Sumaya was saying thank you, Pratik, for a comprehensive and informative presentation. Other colleagues as well, they're just sending their thanking messages.